This is Heart Rhythm TV. I'm Roderick Tung. I'm joined by Miguel Valderrabano on the day after the release of the Venus trial in JAMA. Miguel, welcome.
Thank you.
And congratulations for a blockbuster paradigm shift approach to doing chemical ablation in the vena marshal as an adjunct to persistent AFib. There's so much to talk about, Miguel. Let's jump right into the trial and kind of give a summary for the Heart Rhythm Society and the viewers. So this was NIH funded, and we've talked a little bit about the backstory of that. And this was nearly 350 patients in a randomized way of looking at persistent AFib patients. Can you tell us a little bit about really how, for those that don't do vein of Marshall ablation, how easy is it? How difficult is it? How long does it take? And you guys also had about a 15% estimated failure rate. So talk to us a little bit about the pragmatic, and then we'll get into the results.
So the pragmatics, like any other procedure, you just need to be familiarized with the steps. We are all familiar with manipulating wires in the coronary sinus. You need a few reminders on how to use an angioplasty balloon, which is nothing. And basically the way we started doing this, and I still do it that way, is through the internal jugular vein with a 9-French sheath, and then I get a coronary sinus sheath, any one that we use for left ventricular lead placement. And then I use a Lima, or you can use a subselector, anything with an acute curve pointing upward inside the CS, and you give contrast, and the vein of Marshall almost always is visible there. In our initial experience, we had anywhere between 15 to 20% to 10% failure rate. It was one of those things that as you get more experience, you get better at getting a wire in the vein of Marshall. And we had to obviously get acquainted with details of the anatomy. Not every anatomy is the same. Some vein of Marshall are not there, and but you can have an appendage vein. So there's a lot of variations in the venous anatomy, but we estimated a 15%, being conservative, 15% of inability to cannulate the vein of Marshall and deliver alcohol. And that is why the trial was not randomized 1-to-1. It was randomized 1.15 to 1, so that we had a 15% excess number of patients in the vein of Marshall group, with the idea that we could do a comparison of equal number of patients treated with vein of Marshall as well as catheter ablation alone.
And then Miguel, you allow them to do PVI, and to remind the Heart Rhythm viewership, this happens, you started this in 2013. This is 2 years before STAR-AF2 was published, which really showed that cafes and lines were not beneficial in that study in STAR-AF2. That was about nearly 600 patients. But you allowed them to do others, and then you monitor for AFib and atrial tachycardia recurrence.
Yes.
So what did you find in the differences between the groups?
So a couple of things. So because, like you said, at the time of enrollment, we could not be dogmatic and mandate a specific ablation strategy other than pulmonary vein isolation. That's exactly how we designed the study. We have to do pulmonary vein isolation in both groups, and then additional lesions were left up to the operator. It's a weakness now, whatever. I have no options, and I thought I had to give the patients the standard of care at that time. And so most patients in both groups had additional lesions beyond pulmonary vein. 95% of the patients in both groups, this was identical percentage, had lesions beyond pulmonary vein isolation. 2/3 had posterior wall isolation. Mitral isthmus ablation was mandated, or at least strongly recommended, in the vein of Marshall group. So there were some differences between the lesion sets, minor. Only right atrial lesions were more common in the catheter ablation group, the control group, and mitral isthmus ablation was more commonly performed in the vein of Marshall group.
And then, so you monitor these patients at 6 months and 12 months with 30-day event, and then you find?
So we monitored patients with a 1-month continuous event monitor. This was provided by Medical Algorithms in Poland. So 1 month continuous, no data wasted. At 6 months and then at 12 months. And ablation failures included 30 seconds or more of atrial tachycardia or fibrillation in the monitor, or of course, symptomatic recurrences of atrial fibrillation or tachycardia. So all in all, the primary endpoint, which was freedom from 30 seconds of atrial tachycardia or fibrillation in the monitor at 6 and 12 months, or freedom from any symptomatic recurrence after a single procedure, the control group had only success rate defined as that 38%. The Vein of Marshall group had 49%. And that's absolute 11% difference, which was statistically significant.
Which is a number needed to treat of less than 10, which is pretty darn good for a 350 patient study, right? That you have to give this for 10 patients to help one to give them added benefit. So I think that's incredible proof of concept.
We achieved a different result, that we made a significant difference. What I'm most curious now is to figure out exactly what determines the ablation success. Is it the fact that we have a more reliable mitral isthmus ablation? Interestingly, in the long-standing persistence, which is important to note that more than 50% of the patients in both groups had long-standing persistent. Well, in those, Vein of Marshall seemed to make a bigger difference. And this is one of the subgroup analyses that is reported in the supplements. So I don't know if it's the more aggressive ablation created by Vein of Marshall ethanol. I don't know if it's the epicardial nature of that ablation. I don't know if it's the mitral isthmus being more solid. I don't think so by itself, because if you look at recurrences as atrial fibrillation or tachycardia, they were very similar. So it's not like we prevented perimitral flutters more in the Vein of Marshall group, and that's why the success were higher. Actually, it was more prevention of AFib than atrial tachycardia. It may be that the parasympathetic denervation. So those are things that would be nice to then try to explore in the future. But without the outcomes, then the motivation to look for mechanisms is less. So I'm just happy that we have the outcome differences.
Yeah, it would be fascinating to look at some heart rate variability or autonomic testing afterwards. So I think that's fantastic, because it's very clear that it's probably going to give you more transmural or more durable treatment of that ridge area, and then to be able to complete blocks, and then to potentially the autonomic influence. There's so many potential beneficial reasons as to why this worked. So last couple questions are, you also defined multiple secondary endpoints. And I think you stated in the results that 9 of them, the 9 of them were not significant, or 9 of them were significant, but many of them were not significant. And that shows the challenges of AFib ablation trials in general. What have you learned, and what can you tell us about the secondary endpoints, and then looking at burden and binary outcomes?
Yeah, so burden was the most important secondary endpoint in the study design. I toyed with the idea of making it a primary endpoint. Burden was challenging because basically in the patients that ablation works, they will have very little burden, and they may have 0, or they may have less than 1% burden if they have episodes of atrial tachycardia for 20 seconds or so. Many times over 1 month, you may amount to 1% or so AFib burden. And those are clinically successful cases. So if the ablation had not worked, when it doesn't work, you had 90, 100% AFib burden. So the distribution is anything but normal. And when you try to treat that statistically, it becomes quite challenging. So we ended up finding that using a non-parametric test and Mann-Whitney test, that we had statistically significant less burden in the Vein of Marshall group. And if you have a test that works for you, you like it, right? But when it comes to actually showing the differences in burden, they're very hard to understand. What ended up being more clinically relevant is simply looking at, hey, who has 0 burden? And we just look at the proportion of patients that had 0 burden in the different treatment groups, and we found statistically differences. So 78% of the patients treated with Vein of Marshall alcohol had 0 burden on monitor versus 67% in the controls. And those numbers are more acceptable, because if I tell a patient, hey, you have a 50% chance of getting success, it doesn't look very appealing. But if you tell them, hey, I have a 78% chance of you having 0 burden when I monitor you later, and that's more relevant.
So that difference between 78%, Miguel, and then the 49, which is just 30 seconds, that's about 30% of patients or events that are really these 30-second episodes that don't count up to more than one,
Yeah, and also keep in mind patients. So the AFib burden, the monitors were done regardless of whether the patient had failed already. So if the patient showed up at month, 4 on follow-up with atrial flutter, it's a failure. I shock them and then I follow them. If then at 6 months I do a monitor and have zero burden, that's zero burden. I cannot change that. And the same thing at 12 months. So a lot of patients were in that situation where they had zero burden in both monitoring sessions, and yet they were failures because they had been cardioverted at month 4 or something like that. So it's one of those things that the complexity of coming up with a design for AFib that's very difficult.
Well, I think, Miguel, we all know that one of the problems with atrial fibrillation and where we've been at an intellectual impasse beyond PVI. And everyone has what they believe is an anecdote or a secret sauce, right? We've seen cafes or they've seen one case where they did an anterior line and then it terminates. And then they believe that that's what's needed for all, or they do the CS and we're all waiting for electroporation. And maybe everyone at home is probably thinking, well, I'm not sure I need alcohol because what I do is probably enough or different, or maybe I get better outcomes than this 49%, but make sure that everyone reads the fine print, because I think what we're bringing up here is the very important difference of how to define endpoints with atrial fibrillation. And lastly, I want to congratulate you on a rigorous trial. This is something that you've been so passionate about, and getting NIH funding for all this through. This is not an easy path. It's a path least traveled, and kudos to you. And congratulations on behalf of the whole Heart Rhythm Society for representing us in such a good light with JAMA. So thank you, Miguel.
Thank
and
you.
For all of our reviewers, read in. I'm sure it's going to be a source of multiple journal clubs. But thank you for joining us, Miguel, on Heart Rhythm TV.
Always a pleasure. Thank you.